Good afternoon, everyone. I'm Robert Stepanian. I'm a visiting professor on the Institute of Global Health in Imperial Global Health Innovations. Some housekeeping before. The forum is a monthly platform to bring Imperial teachers, students, and staff from across the Imperial faculties to highlight, discuss, and disseminate findings on current research and innovation on relevant global health topics. So it takes on monthly basis, rotating. We are going to talk today on a very important topic, which is digital health. As you know, it's a massive area, and it's a transformative area, particularly from the global health perspective. There is a live tweet shown on if you are interested, and the hashtag is shown, and the tweet handle is @imperial_IGHI. I would like, of course, to thank Lord Araderzi for supporting this forum, and particularly also for Nikita and Rathcode and Nicolette Davis for helping me for the logistics and the arrangements for the forum. Right, so the first one we are going to talk, it's a joint talk between, are they here? It's here, yeah, I got them. So the first one, it's a joint talk between myself and Professor Brian Woodward, who is a Professor Emeritus in Engineering at Loughborough University. Brian was my supervisor, actually, so he started the whole thing for me, although it was underwater, and then we moved to the land. But I will leave him to talk about it. We have a very interesting, we led two interesting projects, one about mobile health in India and the other one in Iraq. So I will leave Brian to talk. Thank you.
Thank you. Good afternoon, everybody. Can you hear me? Good. Yeah, I'm Brian Woodward, and I used to work at Loughborough University, but I've been put out to grass a long time ago, so I don't go there very often. But I'm familiar with Imperial College because I did my PhD at this college about 100 years ago, a long time ago. And that was in physics, and I've moved to engineering and underwater acoustics and medicine and mobile medicine and so on, so quite a varied background. Before I get on to the project that we're going to talk about, I'm only going to talk for about 5 minutes, and I'll leave Robert for the next 3 hours. I was involved in underwater acoustics for a long time as a diver, and when Robert and I started working together, we were interested in transmitting biomedical signals through the water, such as the ECG or heart rate, breathing rate, and so on. We could do that using sound waves through the water. So it's a kind of digital communications, if you like. And then we moved on to more conventional communications. Now, if I press the right button, this one. I don't think you've got the right thing on the screen yet. There we go. This one, yeah. Thanks. The project I'd like to talk briefly about was introduced by the British Council in about 2006, so this is ancient history to a lot of you. It's called UKIRI, which, as you see, stands for United Kingdom India Education and Research Initiative. And the idea of the programme was to form links between groups in the UK and in India for the common good. So it was groups of scientists, engineers, clinicians, and many others. And we had to have a so-called hub in the UK, which was Loughborough University, my institution. And the one in India was the Indian Institute of Technology in Delhi, which is a big, prestigious university. They have IITs in most of the main cities in Delhi. There are about a dozen altogether. But IIT Delhi we've worked with for at least the last 30 years. The so-called satellite groups were, in the UK, it was Kingston, which was where Robert used to be, And in India, we had the All India Institute of Medical Sciences, which is based in Delhi, but they have lots of local hospitals, rural hospitals all over the place, and lots of links with those. And the other institution was the Aligarh Muslim University, AMU, which is something like 80 kilometers east of Delhi. And we had a colleague there who worked on signal processing. So that was the setup. And you can imagine it involved a lot of toing and froing in communications. So the real aim of this project was to forge links with institutions in India and devise a project and then execute it. I'll say a little bit about methodology and the various tasks involved, the technology that we use, which is now pretty dated, and the way ahead. That's just my thoughts. I won't say much about that because I'm sure that will come in the discussion later on. Well, what we decided to do, our methodology, was to enable remote monitoring of patients suffering from non-communicable diseases, such as heart disease and diabetes, but we can monitor anything. We tended to think in terms of monitoring 4 different parameters, say blood pressure and blood glucose level, temperature, heart, diabetes, anything to do with these two conditions. So we had to devise a work plan which we divided into various tasks that each group had to do, and lots of liaison between the hub and the satellite groups between both countries. And this was really to ensure the exchange of lots of ideas and designs, software, hardware, data, lots of arguments and so on. But it all gradually came together. But our aim was to demonstrate health systems, I think now called digital health systems officially, but that's what we've called it for a long time. And this was to secure a project for particular needs, clinical needs. I am speeding along here, but we'll have time for discussion later on in the afternoon, I think. First of all, the identification of clinical needs. We wanted to establish ways of monitoring chronic diseases remotely. We're talking of thousands of miles in the case of India, at least hundreds of miles, and even in parts of Britain. The communication is not a trivial problem. Developments of sensors and processors using smart sensors and biomedical signal transmission. We had to have appropriate sensors for each condition monitored, like heart sensors, for example, or means of transmitting blood glucose data, say. Network development. So we have signals going from sensors to a mobile device like a phone or nowadays a smartphone, and then using the infrastructure of the communication systems in the country to send that data to, say, a hospital like the All India Institute of Medical Sciences in Delhi. Interestingly, of course, we can use normal mobile communication systems if it exists. It doesn't exist everywhere, no more than it does here in this country in some places. We can use the internet, of course, and interestingly in India we can use a widespread fibre optic network, which turns out to be very useful because it's high speed. Technical and clinical trials. This involved travelling around various hospitals and medical centres and talking to staff and deciding what they most wanted. And all of this involved quite a lot of travelling around, and we had about £150,000 to do it, so it wasn't too bad. That's really all I'm going to say about the task, but I can enlarge on that later if necessary. Here's a very old-fashioned picture, not least because I wasn't grey in that picture, and it was taken about 2006. And my colleague there is Fadli Rashid from Malaysia. He's now a doctor, no, he's professor now, and he's taking my pulse there, but the picture at least shows the essence of a simple setup. I've got ECG sensors on my arms, to just a very simple way of monitoring my pulse rate, or ECG. I've got, they're connected to a box that Fadli is holding. It's about the size of a large matchbox. although much later we made much smaller ones, obviously, and there's no reason why you couldn't have it size of a SIM card or something, or even smaller than that. They're connected by wires there, but with smart sensors you could do that directly with wireless communication links. And I'm holding a phone there, which I hesitate to identify, but it would now look like something out of the Ark. But although that is a dated time of picture, the essence of what we would do now is just the same. It's just the technology increases, improves, and it's ongoing. So in a year's time, 10 years' time, what we think of as smart, clever now will look very dated. So watch this space. This particular test, illustrated by these publicity photographs, was to monitor my heart, my ECG, as I was driving my car along the M1 at 80 miles an hour, 70 miles an hour. And we were able to, I was instrumented with various electrodes, driving the car, and Fadley was sitting there with his computer and a couple of phones, and he could monitor the signals on his own laptop, but also back in the lab. We could look at them later. This was about 12 or 13 years ago, so we did achieve quite a lot then, and then we moved on to the Untitled project proper, which is similar to this. I'm going to stop there without going into what I think about the future, and I'll pass you on to Robert, because you've got a lot to say about the same sort of thing, but in Iraq and war zones and other deprived areas, rather than just India. Over to you, Robert.
Thank you very much, Brian.
Oh, I didn't show the last
Yeah.
slide, didn't I?
You want me to show?
No, no.
All right, so now I'm going to talk about a very important topic that I think really, oh, by the way, Brian brought the book. If anyone is interested in digital mobile health, that's the book we
No, it's so
joined.
cool. We need you to buy the book.
Yeah.
It costs £100.
So this is a very, very important area, which is actually passionate for me. At this stage, for me, I'm an evangelist for mobile and digital health. I would like really this area to kick off, especially in different areas, in different zones. And one of the areas I'm very interested and passionately about is in the poorer areas in developing world, and particularly in the conflict and post-conflict areas. Now we have a major refugee crisis around the globe, not only in Europe but in the Middle East. And one of the areas that I started working nearly now 10 years is in Iraq. So this is, I don't know if you know, this is Harry Sanderson, sir. Sanderson Pasha. He is the founder of the medical school in Iraq and the modern medical education in Iraq, and the first dean of the Baghdad Medical School, and physician to the royal family in Iraq. He lived in Iraq for 25 years and established the medical education system based on the British system. Unfortunately, now if he sees what's the situation there, he will be disappointed. What I'm going to speak about is the Delfy program that was funded by the DFID at the time in 2009 and ran from 2009 to 2012. Also there was a charity, Cara, that supported similar project. So basically at the time, 2009, the UK government decided to invest a chunk of money in developing educational programs between UK institutions and in UK and Iraq, and the project that I led was actually dealing with e-health and m-health, how we can introduce e-health and m-health into Iraq, which was, I think, a new area, still a new area. Current status in Iraq is very difficult. Nearly 1/3 of the population needing dire health. There's about 2 million displaced people internally. The healthcare delivery is problematic, as you know. So, of course, this is a result of nearly 3 decades of wars and problems in the country, and definitely there's a lack of quality of healthcare services in rural areas, especially in the primary care sector. In Iraq, most of the services really focus on the primary care and not much on the on the secondary care. Of course, after post 2003, I'm not sure if things improved. Yes, they had some modern device, equipment moved to the hospitals and things, but in terms of the education, the healthcare education and innovation in improving delivery, I don't think things have moved forward. So the aim of the Delfy Iraq project was to introduce two things: introduce mobile health and e-health into Iraq, and to conduct this through two pilot studies. So what we did, the two sets of pilots, one was in Baghdad and the other one was in Basra, the biggest city in the south of Iraq, and that reflect an important healthcare need, which is of course diabetes. Diabetes is a major, one of the major chronic diseases in the country, and there isn't much about really knowing how these people are self-manage themselves or educate themselves. And we did it in a frugal way. One of the things that, what I'm going to speak is about the frugality of the method. So a simple SMS method can really improve a lot in terms of the improving the outcomes. So the first one was the Baghdad pilot study was feasibility and acceptability of text messaging to support antenatal healthcare in Iraqi pregnant women, a pilot study. So what we did is that we devised, as you can see, a self SMS method. And as you know, one of the key success stories on mobile health from the global perspective is really text messaging, because it's simple, it's doable, and it's very possible to be done in poorer regions. And so what the crux of the matter is of the project was to send educational text messages to pregnant women with gestational diabetes, and to tell them to make them aware about the diabetes, because as you know, gestational diabetes now, it's a problem. Is a lot of the women, they don't manage themselves very well during that period. It only happens during pregnancy, but then after that, if they don't manage it, there's most likely that it will move to type 2. So what we did is to educate through these standard educational messages for diabetes, and we split the two groups, control group of 146 pregnant women and intervention group, which is the SMS mHealth group, at about 97 group. So the women basically were asked to complete a questionnaire on how to assess their healthcare information feedback using the SMS method on their phones, and to evaluate the effectiveness of the SMS messages on their attendance in maternal clinics. So what we discovered is that the people were really very anxious to do this. I remember I was sitting with the doctor, colleague of mine, Dr. Taghlid Al-Haidari, in Amman while we were discussing the project, and she was really having all these text messages from the women in the pilot about what to do now, what do you think I can do. So it was a very interesting thing. And what we found very interesting results is the number of visits with medium of 4 in group with the intervention compared to control group. So we had more people aware of their diabetic condition, and they were anxious to go to the clinics and understand how they can better manage compared to the control group. So, and this is some of the results. You can see that we have a very high percentage of the women subjects that are agreeing on the issues that we address in the text messaging programs. So basically, they are in average they are above 75% of the control group. The second pilot study was in Basra. This was more of a sort of text messaging to support education management of type 2 diabetes. So what we did, we recruited about 50 patients in type 2, following type 2 diabetic patients, and again they have to complete 2 sets of standard questionnaire, one at the beginning of the pilot and the one Again, the idea is the same: is educate them on awareness of their diabetes condition and how to better understand their condition using SMS. And I think it was 6 months follow-up. The result of the study have shown that sending educational text messages via mobile phone will significantly increase the knowledge of participants about their condition and enhance their educational awareness about the diabetes. And the knowledge of assessment post-test questionnaire significantly increased from 8.57 to 9.85. And it was this study proved that it is consistent with similar studies that are done globally in other areas, but this is the first study. And actually, their HbA1c of the intervention group was much lower than the control group, which is very interesting. And both studies were published, as you can see, if anyone is interested to. So as far as I know, this is the first studies about mobile health in a conflict or post-conflict region like Iraq. Another of the achievements of the project was that we established an e-health unit in Basra particularly, and because they opened a new medical school there. And of course several conferences and meetings with the Iraqi clinicians and their training, both in UK and in Amman, and 1 or 2 in Basra in Iraq. What are the lessons learned? That's the thing. That's the key thing. The problem with countries like Iraq is that once the pilot goes, there is no sustainability. So they just forget about it. That's the problem. How we can really embed these technologies into their mindset is really very traditional. Although they understand that these technologies and the future, so there is a very limitation into their, and this is a major problem, is that their education is very classical, very, their medical studies, they are not geared toward introducing innovations and new ways of delivering healthcare, and this was the major thing. But they are very receptive. They would like really these things to be introduced. But of course, after post 2014, there was more of the political turmoil and things like that. So, and so there is a challenges in introducing digital health or mobile health into post-conflict or conflict regions like Iraq. Is that there is a lack of vision. There's no strategy. Of course, there is. They had some e-government strategy, but. Of course, the corruption is another major thing. Bureaucracy and the lack of, and this is very important, the lack of specialists in educational programs that can educate the new generation on digital health and how this is very important and transformative for healthcare. Why it is very important in Iraq? Because under post-conflict, Iraq is just an example. And now we can see a major conflict in Yemen, in Syria, neighboring Syria, millions of refugees, and these people have no or very limited healthcare delivery. And I don't think anyone is thinking about how better we can use these frugal digital health technologies to really improve or deliver some sort of a basic healthcare services in some areas that can be done easily, like the one I have shown. So there is now, I think, there is a possibility initiative from Surrey University that they are thinking of setting a center for the whole area of supporting Iraq, but it's still at an early stage. So that's it really. Thank you very much. Next, I think I'm going to introduce my colleague, Dr. Mike Short. Mike is currently the Chief Scientific Advisor of the Department of International Trade. I've known Mike for a very long time, more than a decade. Mike was one of the first advocates of mobile health and digital health in his capacity as He held several industry and institutional position in UK. He was president of the IET, as I remember, president of the GSMA. He is very active in the telecom area, and he was the vice president of O2, Telefonica O2, and as far as I know, Mike was one of the first advocates to push forward for the development of mobile health. And I think he's going to talk now a very interesting topic about how mobile health, especially in Africa, and I will leave him also to co-chair the session with me. Mike, please. Thank you.
Where have you put it? PDF. Bottom right? There?
Yeah.
Okay. So sorry it's in PDF format, we had to change computers at the last minute, I'm sorry about that. So it's good to be here, thank you very much for the invitation. As Chief Scientific Advisor, I have to give advice in all sorts of areas of trade, including telecoms, sometimes health, sometimes life sciences, sometimes automotive. And it's largely with the lens of working with international countries from a trade point of view, whether it's export or inbound investment. But today I thought I'd talk a little bit more about digital health with the lens of Africa, and in particular draw on some of my telecoms and mobile background, and to also explain a bit more about why I would call it digital health today rather than M-health. So I've had 30 years in mobile, but actually the last 18 months or so in government. But I'd like to start by just looking back at the last century for a few minutes, if I may. Who knows, or who would like to give me their best idea of the biggest inventions of the last century that are helping us all today? The biggest inventions, 3 or 4. Who would like to start?
Light bulb.
Light bulb, that's an interesting one. Any more? The internet. Well, that was one of my lists anyway. Okay, any more? Telecoms. Particularly some aspects of telecoms, like maybe mobile, but telecoms I think has had a growth curve. But if you point to 1 or 2 things, certainly mobile I would say. I'd also link in there GPS, navigation systems, because that affects everything and certainly is a key enabler for digital health, if we think about movement of people and so on. Fibre optics I think is certainly part of the telecoms journey. Any? Cloud storage, thank you. Well, I'm pleased somebody mentions the computing route, which now we often talk about with cloud storage in mind. Certainly when the computer was invented, there was nobody thinking about the cloud, never mind connecting to the cloud. But also it means that we can now process so much more data than ever before and actually give people access to that data more than ever before. Any more?
Social media?
Social media. Some say it's a bit like taboo occasionally when you say digital health and social media, but I think the internet itself has enabled so many things, particularly social media. But actually, social media wouldn't have been successful without mobile. So I would tend to suggest mobile and internet lead to social media. Any others?
Travel luggage on wheels.
Wheels. Well, I think wheels predated. I mean, you might say the car, but the car was really invented in the previous century rather than the last century. What about the jet engine? You know, and if you think about the impact of the jet engine on food and how that transfers disease around the world as well as people, you know, there's some good bits and bad bits with many inventions, but actually it's changed the whole way we look at tourism and travel, but it's also affected the way some diseases and food travel around the world. Any others?
Atomic bomb.
That sometimes comes up. I think the nuclear developments are certainly significant. We might pick out some energy areas as well.
Genomics.
Sorry, genomics. Yeah, I think so. But it'd be interesting when you say if they're the big ones from the last century, what are the big ones for this one? And I would suggest to you something in that digital health space might be an interesting new one to think about. And certainly some of those enablers with those inventions are really helping us deliver digital health. But if we start to think about how it's helping us, it helps us in different ways. Just, there we go, right. So sometimes I start with this because we can get very pessimistic about the world, can't we? I actually think it's not always raining, it's not always a sunny flag, but actually there's lots of opportunities. And I think digital health is one of those ones. Some things we do from a UK government is to support innovation, science, technology in various ways, whether it's the research and innovation activity, whether it's funding for British Business Bank and suitable causes. The industrial strategy to give guidance, of which the UK industrial strategy does give guidance and priority to healthy ageing, which is an interesting area for digital health. And areas of investment. But areas of investment such as AI, artificial intelligence, are going to come up in my brief talk today. But when I take some slides from the GSM Association, which is the association of all the mobile operators, they often look at a picture through to 2025. And it's interesting that next week we have something called Mobile World Congress, where we, the UK government, are supporting 150 companies, UK companies, going to Mobile World Congress. 108,000 people expected, roughly. Significant show from a trade point of view. It's not a consumer show, it's a trade show. But actually it's about people exchanging knowledge and ideas. So the GSM Association that run that, it offers a very useful vehicle to help those ideas get exchanged and case studies exchanged. But this prediction came out late last year, and we'll see some later figures probably released next week. But it's interesting that it's put into three kind of pillars. And if we think about the mobile bit, we are entering into something called a 5G era. I'm not going to say it's for Africa yet, but a 5G era which embraces much more in the way of mobile, including Wi-Fi and satellite as well as fixed broadband. But that's likely to lift the number of customers closer to 25 billion from the 9.3 billion today. So this is the most inclusive technology on the planet. We need to think about that from a connectivity point of view, but also it's the most inclusive. Yes, there are coverage gaps. Yes, there are issues with price. Yes, there are issues with service and speed. But this roadmap towards 5G, which will deliver much higher capacity and much higher speeds, is an interesting roadmap to follow. It's also interesting that they put in the middle there artificial intelligence and the rise of artificial intelligence, only as good as the available data, only as good as access to patient records, only as good as the systems that may exist. So to me it's much more digital health now than mobile health. It's actually how can you use these systems end to end in a systematic way, whether it's in a developing nation or a developed nation. Clearly the rise of artificial intelligence will give us much more power of suggestion and prevention, give us much more capability to do alerting schemes. SMS is a very good start point, but actually email and artificial intelligence is taking the data revolution into health in a way that is not typically taught. And lastly, the Internet of Things. And the Internet of Things, we're starting to see more and more connections, not just to people, but also to things, objects. So the smart city will have much more connectivity. The car, most cars will be connected. Things in the home, we'll see more and more devices in the home being connected. And so if we think about the volume side, up to the 25 billion, a lot of that is going to be the things that are connected, not just the people. So what would that be? Medical devices, sensors, maybe remote instrumentation that could be used in some cases. Some of the capability on the 5G side also will lead into areas like telesurgery. Now that's the world we're going into, that's not the world of Africa today. But when we apply that technology without it being tech push, it's very clear that some countries are lacking the clinicians they need. So this is not a substitute for clinicians, but this is offering a bigger toolkit for clinicians of the future. When you go to some parts of the world, you notice they don't have hospitals in every town. You notice they don't have GPs on every corner. They don't have those facilities. So I'd like to talk a little bit more about the frugal end of the market rather than necessarily the developed world, if I may, from here on in. It's quite interesting though when we see that combination, it's not always put together. And please bear in mind that the smartphone is only 12 years old if you take back that to the origin of the Apple iPhone. Some of what Robert and Brian were doing was before the smartphone existed. So even before the internet played a part in this roadmap. But actually what we can now see is much more access and information exchange from the internet rather than it being text-based or email-based alone. So the internet will play a key part in all of this, even though I only said Internet of Things on that chart. So these slides are taken from the GSM Association, and in there are some useful references. All the slides I'm using today I'll leave with the organisers if you want to see them offline, because there's a few other references you might want to pick up. It's a useful source because it represents 800 mobile operators around the world. There are coverage maps for every country. There are case studies in many areas, not just digital health, but in other areas as well. There are some really useful references which help you get better marks in some papers you may be writing for studies or research. But there are some really good references. And I think it stands alongside the World Health Organization for statistics. It stands alongside other valuable sources such as the ITU. And I was proud to be chairman of it in 1995-96 and helped to steer it to where we are today. So this describes it. It was founded in 1987, 30 years ago, headquartered here in London. 800 operas are shown there. 200,000 delegates go to their events, of which the Mobile World Congress next week is one of the key events. It covers areas where collective action is needed, so it's not anti-competitive, it's pro and pre-market. It's supporting areas of development towards next generation mobile. It also helps the mobile industry look at sustainable development goals. And I think that umbrella of the UN Sustainable Development Goals is a very good umbrella for dialogue as well. You know, people are exchanging knowledge around what are those 17 development goals, how can they be achieved by 2070, and digital health is a key part of that. So when we look at it, if we take about unique users, at the end of 2017 it was 5 billion unique users. It's roughly probably about 5.4 billion unique users today, of which around 3.8 billion at the end of 2017 were in low and middle income countries. So it's not only the most inclusive technology on the planet, it's the most inclusive technology in places like Africa and the low and middle income countries. Because it has reach and capability that's extending all the time, based on 2 to 3 billion phones being shipped every year, 2 to 3 billion being shipped every year, that capability is being increased in terms of all sorts of areas. Some of you may not know, but if the web is 30 years old next month, March, the camera phone is barely 20 years old next year. Barely 20 years old. The camera phone capability is increased to being the megapixels capability of granularity. It's also covering color and video. Didn't do that at the beginning. We then look around this. Around 2 in every 5 smartphone users use their phone to look up issues for work or for family to improve their lives as well as family's health. And it's particularly important in areas like education. So one of the reasons I do these sorts of talks from time to time is I think actually education is as important as the health or the other benefits that may come from these sort of devices. If we take the Mobile for Development Programme, which is run by GSMA, they concentrate particularly on these UN Sustainable Development Goals, all 17 of them, and there'll be more reports on that. But actually they can point to case studies that have impacted 44 million lives. Many in health, but some in access to water, some in issues like payment methodology. So in many countries in the world there's ways of paying with a simple text message. You can transfer money from A to B where there are no banks in some cases. It may give you access to pharmacy because you can pay through a mobile money type transfer. It may give you a mobile identity. In some parts of the world they don't have effective record systems at birth registration. So a mobile identity is used in some countries such as Pakistan where they don't have comprehensive record systems. So it's helping on a systems level, not just on a hearing, speaking or transfer of data level. Here's an overview, and you can see mobile health is singled out as a key program. To just touch on some of the others, mobile money is more about transferring money, which could be useful for the payment of some health services. Humanitarian innovation, clearly I think, touches on digital health. The example of Iraq illustrates that, but actually displaced people, a lot of them do carry smartphones. They're not all doing that, but sometimes they use those smartphones to identify themselves. One of the shortlisted companies, a British company, does some work with blockchain and mobile with Syrian refugees in Lebanon, and actually that helps them to be identified on a one-off basis with a digitized camera picture to get access to education and health and pharmacy. Humanitarian innovation doesn't stand still, so clearly as humanitarian issues occur, then clearly there's also support from the industry in that area. Utilities, the ability to buy and sell electricity is not as universal as we might expect it in the West, particularly when you go to some of the developing nations. So how can you unlock it to be both affordable and sustainable? And that impacts also health if some of those utilities are not so affordable or accessible. Things like connected women and connected society is about helping the mobile internet adoption, how to illustrate that in a more collective way and cost-effective way. Digital identity is about some of the birth record points I made earlier on, and then some of the areas around innovation and agriculture. Oh, thank you. I should have done that first. Some of the areas around innovation and agriculture or agri-tech are quite interesting. There's a social media network which doesn't just help farmers, but it has a byproduct in health. It's called WeFarm and has 1.4 million users, farmers, who are exchanging information all around agri-tech to help with crop protection and eradication of disease in an agricultural sense. And I think that's quite interesting because the security of the food supply is as important as one's health, making sure that that's resilient as well. Ecosystem Accelerator is about improving innovation and understanding. So I'm now going to move to that. There we go. And so these programs have been recognized. So, for example, Millicom, interesting quote there about the Internet Skills Training Kit. How do you share knowledge in this area to actually improve knowledge about what mobile and the Internet can do? Penny Mordaunt, as Secretary of State of DFID. DFID have been a long-term supporter of the mobile activities, whether it be mobile money or the program you referred to earlier on, Robert. Rory Stewart, when he was at DFID, also was an active supporter. So there's been strong governmental support historically from the UK government at least, and I think it's seen that this sort of area of digitization can actually uplift an economy in all sorts of ways. And I said I wasn't going to go through all the references, but here's some good ones. So the top, the connectivity index and the courage index is a very good indication as to the levels of connectivity that occur in every country. So smartphones are not pervasive in every country, let's be clear on that. But there are more people in Africa that connect to the internet through mobile smartphones than through any other means. You know, by volume, it's mobile. So even if everybody doesn't, that's growing. And I think the main growth we're going to see is in countries like Africa. So what you've then got below that is some mobile economy reports, which are all updated both globally and regionally, once every 6 months. You've also got the commitment to the UN Sustainable Development Goals that illustrates many other solutions that may occur across the development goals. Areas to do with sustainable and responsible business that relates to that, so how can sustainability help digital health? And then areas to do with programs, creating a better world and so on. And you know, you can see, 2017 report, 2018 report, it's to try and reach and share knowledge in a productive way. They've also got a campaign, particularly for that AI area, big data for social good. How can data be released from a variety of areas? Now, the record systems in some parts of the world are non-existent, as hinted by Robert and Brian's points. They're not existent, but as data gets aggregated, it's quite important that data can get aggregated for better sharing. So I'm involved with a program called iSense, which is co-hosted between Imperial and UCL, and it's looking at diseases such as Ebola and influenza and epidemics that could be associated with HIV or MRSA, and that's doing point-of-care testing. The point-of-care testing is only as good as the data repository you keep it in. Otherwise, how can you manage the flow of diseases that may cross borders? But the big data for social good is looking at how can you gather data but also release it to share it for better purposes. So, if a mobile operator knows where people are, it's not going to release anything confidential about an individual. It's not going to release a name and address of a person. But it might be able to track people across a city. So if you can imagine in the morning, a city fills up as people commute in and then it moves out. Some of that data for visualization is very helpful when thinking about epidemics and the spread of disease. So starting to use that visualization technique is important as a source of data. I think in time, as people have more and more apps or wearables, I think we'll see other data sources helping. There is one reference not on these slides which I'd like to just highlight, which is important, which is there's something, a website called Health Scouts, and that's K for Scouts, S-K-O-U-T-S. And on there are 150 type-approved mobile application solutions, some which are device-based, some which are app-based. But that 150 is about 140 more than a year ago. And that area of getting approvals, whether it's from the US FDA or the EU system, is really just going through the roof. So more and more people are beginning to look at those wearables, those apps, and get an approval, because now the approval authorities are saying, yes, digital health is part of society. Now, I'm frank and have to say that the majority are used in the Northern Hemisphere, and in the westernized countries, they're not really used in Africa or Asia yet. But I think that rate of growth is going to open up new ideas to how you can deal with things like diabetes or blood pressure. Some of them are linked towards simple measurement devices that plug in as wearables or as sensors. So I think watching that Health Scouts website would be useful for those which are type approved and therefore, by implication, evidence-based and more trusted. I think there's reference to better future there, there's reference to big data for social good. I'd like to just finish off before we do the panel on a few things that still surprise me. So I said next year is the 20th anniversary of the camera phone. And when it was invented, people said, why do you want to put a camera inside a mobile phone? You know, we used to carry a little, pocket camera, and so why do you put the two together? Well, at first, quite a few people couldn't imagine. So just because the tech could integrate the two doesn't mean that people aren't trying it. So these few pictures just show a few areas where the camera is being used. And I would suggest to you that it's not just the data and the artificial intelligence and the sensors, but I think it's also some of those other things that we can integrate which will make a big difference. So if we take camera phones, who would have thought that they used to climb a ladder to read every meter in northern Pakistan before sending out the bill for electricity? Why don't you have a selfie stick, which wasn't invented 20 years ago, and take a picture of all the meter readings and then send out the bill in a semi-automated fashion? Saves the climbing up the ladder and down again all the time. So this was taken in November 2018 and had only been used as a selfie stick with a camera for about 18 months before that. I find that strange, but people think about using the tools that exist in different ways. This is a Chinese tourist in Frankfurt, taken on March the 2nd, 2017. Now, if tourists can use a selfie stick like this, why don't we use the camera phone a bit more in the health world? If tourists can think about this. Now, in the iSense program, which is, as I said, is co-hosted Imperial and UCL, we've been taking things like sputum samples and blood samples in parts of Africa and seeing if the sample in the holder changes colour. And then with the camera phone, send the data back to a data collection centre for more detailed analysis. But when you don't have a hospital or GP on the corner, you might need to use techniques like combinations of camera phone, internet, cloud storage in that sort of way. But I also think some of this has to be taught in classes and college, because if people don't think about linking these technologies together, it won't happen. These are guests taking pictures at the L Runway presentation at New York Fashion Week, September 11th, 2017. Fashion shows didn't used to be like this. But if you think about the things that we carry a camera phone, why not use it? But we might also carry other things like wearables. So I've seen fashion shows where fashion includes wearables, such as wristwatch monitors, such as eyewear, such as belts. Some of those sensors on the body are starting to be shown at fashion shows, and I think we'll see more examples of that creeping into healthcare gradually. This tragic as it is Honduran migrants taking a caravan north towards USA. What do they take with them? Their smartphones, because it's a way of staying in touch with their loved ones and maybe getting information about the destination. Whether they get across the US border, I don't know, but that's a charging area for those smartphones to keep them in use. And even in religion, camera phones are in use. I think this is Pope Francis. Yes, it's Pope Francis. It was taken in the Vatican in August 22nd. So when mobile phones can come into religion, then they might also come into health. This is a picture of a 75-year-old Vietnamese food seller. Who would have thought going to Vietnam you'd see a food seller, slightly bored because she's not selling enough, looking at herself or doing a FaceTime, having a bit of fun by the side of the road. And in case there are presentations which don't have Donald Trump in them, I thought I'd just include this one. He is hidden right at the back in case you can't spot him. But it's just interesting how, a young black leadership summit might bring out all the phones and just take pictures of that little memory there. It's the man in costume waiting for tourists to take pictures under snowfall in Times Square. Not quite sure why he's dressed as this, but there we go. And even in sporting events, Tiger Woods, how can you better the Tiger Woods golf swing? You don't have to be a golfer to understand that people are following it and they're joining in the experience. And last slide, and then I'll finish. This is a picture, a nice picture, I think, because it's got somebody checking a cell phone rather than looking at the fire behind, which is in the Cleveland National Forest in California. So people are capturing moments. And my point about these camera phones is not just the history, it's also we're going to be capturing moments for digital healthcare in all sorts of different ways in the future. We're going to be capturing moments visually, but also with sensors. we need to have a system that's robust enough to make sure that what is captured accurately with a time and a date stamp, and it's changing diary management. It's going to change the way we record and keep that data, but it's also going to change the way we might visualize that data and share the data with different clinical professions in mind. Thank you. Any questions? Silence. Madam.
You talked about applying a lot of this knowledge in Africa, and my one question is, assuming all the data is collated, big data, where Africa has a lot of very clever people who probably the last time you looked at a textbook was maybe about 20 years ago, and as well as those who are very, very active in what they do and very up to date, but the culture actually, it stops development. How do you go through those hurdles? Because I found it really interesting.
Well, I think education doesn't stop at school or stop at university. You know, I believe in lifelong learning, and it's very obvious now when people look at the internet, they can get information almost in real time, almost anywhere, anytime. I think the same will apply to business, the same will apply to healthcare systems, the same will apply to government. Now, clearly, there are gaps in people's knowledge and understanding in this area, and some of the things I've shown there are a little unusual. However, the pace at which change is moving will mean that some will want to keep up. So some governments are actively looking at digital health as a focus to say, how do we upgrade our digital health systems to be fit for the 21st century? That requires them to think about investment and skills and also, you know, just affordability. They need to make sure it's a practical measure. So some of the whole data story is not just touching health, it's touching other sectors as well. So when governments talk about smart cities, they don't always say smart, they sometimes say healthy cities. So how do you think about the environment and measuring the pollution or minimizing it? How do you think about controlling the transport so it minimizes the pollution? The whole shift towards the electrification of vehicles. So we can't look at what you just said, I think, in isolation from health alone without thinking about how to upgrade the economy and its adjacent sectors. I don't think there's a simple solution. I think unless we share the knowledge, we can't really progress. But I think we're trying to share the knowledge. And I think people, whether it's in a frugal economy or non-frugal economy, will take the best of what's available.
Do you offer funding, or do you expect the users to take the information directly from their internet for free?
So I think because we don't all have a public health system in every country in the world, sometimes it's very much private health. I mean, I've been shocked to see how some pay-as-you-go contracts in mobile have included a health insurance element, have included a funeral in service type death element, maybe paid as part of an insurance policy, but we can start to see combinations of that. So I think the payment side, I think, does depend really on the appetite to invest in this area, and I think government has a key role in that area. Not all government is as centralised or thinks the same way. So. Any more? Sorry, madam, go on. Yes.
There's also a question for this gentleman, I believe.
I saw your hand first, don't worry.
Thank you, it's been utterly inspiring, amazing. I have just one concern, and you might be able to set my mind at rest, but some years ago a contact of mine in the World Health Organization, who was, amongst many other things, an electronic specialist, said to me that mobile phone technology will not be safe until at some point in the 5th generation. And when I was asking him why, he said it's because the hertz that the mobile phones vibrate at are not compatible with the hertz that human beings vibrate at, and that problems with the immune system, etc. And I just wonder, I'm not at all a specialist in this area, but just from a little bit I've read, I've sort of seen one or two worrying articles that suggest that the early 5th generation stuff is still not safe. And I just wonder, because what you're talking about is so empowering for countries where you don't have landlines, where the rural areas, it's just so exciting. But I just have that concern about safety, what your view is, and also if you agree it's not currently safe, how soon might it be safe?
Well, first of all, I don't think there's a proven difficulty so far. radio's been around since Marconi, been widely used in a portable or mobile sense since World War II. So even if the frequencies change, actually it's been around a long time. I think getting to something like 9 billion or so connections also says that there's a lot of it already out there. If we take the particular characteristics of 5G, which we don't yet have, it's still being trialled, already the safety limits are tighter than earlier generations. Already the research has started independently of any vendor, operator, or whatever, much earlier to make sure that we're not adding in risks. I think there are always going to be some people who don't like the idea of new technology, and I acknowledge that. That's fair to everybody.
This person was a really high-tech
No,
person.
no, I'm sure there are experts there, and there will be different views. But I think the fact that I feel comfortable talking about it means that I think it has to be in the open. So if there are discovered evidence points that show there is a risk, then things slow down, whether it's standardisation or deployment. That's why we have trials. And we've had trials in the UK, in Bristol, Surrey, various other places in the UK already. Some have been concerned about other things, like no more masts, please, or is there a radio worry? They have been addressed head on. I actually gave evidence to something called the Stuart Inquiry, which was in Parliament some 15 or 18 years ago, and I think that's a very healthy document. It's laid down certain rules for the UK, and I think those same rules apply for today. But the fact is that after 18 years since the Stuart Inquiry, actually there's been no real problem identified globally. I mean, there's individuals who have views, but there's been no kind of evidence of real health concerns. Who's next? Robert, you had a question?
Actually, I have a follow-up. It's a very good question because since 20 years, there's a concern whether actually the phones are causing cancers. And there's no study now because we're having a very big increase in cancer. Of course, one of the things they are brain cancer that I'm thinking about. Is there any link between this massive usage of phones and tablets? And remember, kids now, as age as 4, they are with the tablets, are affected by the phones or not? That's one thing. It's an open question. Because
Well, I think the Stuart Inquiry did say it's advisable to limit school children's use because they're not fully developed. I think that's a reasonable recommendation in there. We might also say that when you're not using it so close to the body, it's in front of you rather than to your ear all the time. Maybe that's a different paradigm. The link to cancer, I think, is a little worrisome when you raise it, because I don't think there's been a proven link to cancer.
My question is a philosophical question.
Yeah.
What is digital?
Yeah.
No one knows the answer yet. I'm one of the thinkers thinking, what is digital health?
Yeah.
And what it will be the difference between it and what has been done in the last 15 years on mobile health?
Yeah.
That's the question.
Well, I tend to think of it on a systems basis, and it's not just mobile, it's wearables, it's the data. I think it's the system being put together to the benefit of the patients, wherever those patients are.
I think it is a rebranding of mobile health to include artificial intelligence, genomics, and big data analytics.
And I'm happy with that.
Yeah, so that's thing.
Yeah.
Added to the existing in health, that's called digital health. But the thing is that, because I will talk later about it, because now WHO is going to release very soon digital health interventions, I think next month.
Sure.
And the thing that is very interesting, because I was one of the experts evaluating that, most of the evidence was based on mobile health interventions. Because digital health, there is no evidence of digital health yet.
It's insufficient, but I think there are plenty of case studies. Any more questions? If not, I think we should move on. Robert, we're going to have the panel now, or is Michael going to speak?
No, I think we have 2 speakers.
Okay, so the next speaker we have is Michael Thomas. Michael, in the room? Yes. Sorry, I didn't recognise it back. So I hope I'm stolen your thunder given some of my references to iSense. You can explain it much better than me. So Michael Thomas, Research Associate, Department of Materials, Faculty of Engineering, Mobile Phone Connected Diagnostics. The floor is yours. Okay.
Yes, thanks very much, Mike. So you set me up quite nicely for going into a little bit more depth on some of the iSense areas that particularly have been studied within Molly Stevens' group at Imperial College based at South Kensington. So, as Mike said, I'm going to be talking to you about mobile phone connected diagnostics. So I'm a research associate in Molly Stevens' group. I've sort of got a chemistry, physics background, and my focus has been on the development of rapid tests for HIV diagnostics. So a lot of the context of this is going to be within the field of HIV diagnosis, and particularly thinking about resource-limited settings. So I'll start with this. So again, taking HIV testing as an exemplar, what does our kind of state-of-the-art diagnostics look like within a laboratory hospital setting? And it's something like this. Anyone familiar with this would recognize something like the Abbott Architect machine. These machines are great because they essentially automate the diagnosis. They are fully automated liquid handling machines. They can do all of the different steps of the assays that you require. They can do it very reliably. They don't require human intervention to perform the actual analysis, and they use commercial components that are just brought in, installed in the machine, and you can run the system. That means that they're incredibly reliable and dependable in principle. They all contain this element, computational element, so that's required to run the machine. But importantly, it also does something with the results. It connects it into a system. In the case of the UK, it connects us into a healthcare system that's able to action on that, take that data, bring it to the attention of your healthcare professional, who can then action that on that data, put you into some kind of pathway. And this is one of the critical components of this, and how you get a healthcare system working effectively using these kind of diagnostics. But what if you're in a setting which is more resource limited? Perhaps where you don't have centralized testing facilities, you don't even have cold chain sort of control of your even abilities to get materials into your testing scenarios. You can't envisage something like the Abbott Architect. And instead, people are working quite heavily in the space of trying to shrink these systems down with microfluidic technologies. Essentially, you're doing the same kind of thing, but you're miniaturizing it. Perhaps you're using a mobile phone device to perform the computational element of that, or a bespoke device that's running this system. Or alternatively, you're moving towards something more akin to a paper-based rapid test. In principle, it's kind of the same thing. So you're guiding liquids around bits of paper based on the fact that liquid wicks along paper. They tend to be very simple. So these kind of systems are moving towards something that is, I like the term, democratizing diagnostics. So this is enabling technologies that can be used very easily by potentially untrained people, maybe even thinking about people who might want to use diagnostics within the home setting as well. So this is where I'm going to focus my attention. So some of you may be familiar with the assured criteria. And so this is a way of defining what a point-of-care diagnostic ideally would be. It covers things like the cost, how easy it is to use, does it actually work well, is it user-friendly, so usable by the correct audience and users that you want to be using it, whether that's a self-tester, whether that's a healthcare professional. Equipment-free, this is a key point, so ideally you want to have a diagnostic that's not going to require you to have that massive Abbott Architect system to make it work. You want to have something that's very simple, potentially disposable. And of course deliverable. It needs to get where it needs to be used. It needs to withstand that supply chain to get where it needs to go. And very recently, this has been updated to reassured. And this includes now real-time connectivity, which is an absolutely critical component of this. This is coming back to that computational element I mentioned earlier. So the ability to actually take those results and do something with it, connect it into a system where you can actually take that information and start to provide treatment. It goes much deeper than that as well, beyond just providing treatment as well. Environmental friendliness, you don't want to just have lots of disposable materials these days. You want to make sure that you're doing something that's not going to harm the environment. And then ease of specimen collection. This is a really key one when you're thinking about self-testing, for example. Are you using blood? Are you using sputum? Are you using saliva? Are you using urine? Some of these are much easier for people to collect themselves than it would be for a trained healthcare professional. And so the key part of this that comes under this R is the connectivity. So you can, there's many ways that connectivity is beneficial, particularly in resource-limited settings. But this generally applies worldwide, I think. So that linking results into healthcare systems, keeping people within a healthcare system as well. So not just giving them a result, but actually maintaining them within that infrastructure, getting them back when they need treatment or further additional care. Quality control, making sure that the tests are actually working as they should, that they're being used as they should. Avoiding stockouts, so again, thinking about if these tests are precious, if you don't have many of them, how can you ensure that you're using them effectively within a population? If you can monitor that more effectively by obtaining your results, knowing what the results are, and generating useful data sets, that's key. Disease tracking, outbreak control, thinking about long-term community medication programs as well. So our collaborators with iSense are the African Health Research Institute, so they have large population studies looking at how to monitor the efficacy of new treatments. And a key part of that is connecting that data, collecting that data, and then monitoring whether these interventions are successful. So sending data back to people. So these kind of systems that can take advantage of a mobile phone network, for example, on your mobile phone screen, educating people as well. So even if they come out negative in a test, can you inform them and ensure that they're reducing their likelihood of getting an infection downstream? And things like location data, geospatial tagging of diagnosis events, which is again feeding into all of those other ones. So in terms of the mobile connected RLS user group, who are we thinking about here? So the way I'm going to focus this more is thinking about a healthcare worker who's more in the field, so very removed from a laboratory testing setting, and also self-testing. So potentially people at home who are not going to have necessarily a computer, but they might have a mobile device. So one of the big challenges of rapid tests, so these lateral flow paper tests I mentioned earlier, which are ideally suited to both of these scenarios, is actually that they can be quite hard to read. One of the big challenges here is that the method to measure the output of a rapid test is to look at the build-up of a coloured line. You may recognise this from pregnancy tests, these kind of technologies where you see the presence of a line that indicates you're positive. You may have multiple lines on that device that mean different things, and you're required to interpret that and make an appropriate decision based off that. However, the issue is that even with healthcare workers, for example, as Kalinga recently showed, but a lot of people have looked into this in the past as well, even when you're trained, it's still difficult, particularly when you've got test lines that are very faintly positive. So you've got a white strip of paper and you've just got a very faint coloured line. You start to run into issues as to whether people can actually see that or not. Colour blindness, for example, can make this more challenging. Other things that come into the equation are also things like the actual performance of the assay, handling of blood, dispensing it into the devices. These can all be quite difficult, which means that trying to create diagnostics is partly about trying to make them very user-friendly and simple. So some of the technologies that are being worked on at the moment in the mobile tech space, at least, is trying to remove the user error from these diagnostics, but also support the instructional side of how you perform the diagnostic. So there's a small selection of some of the companies that are working in this space and some of the sort of academic outputs that are coming out here as well. So I'll give the example of the Novarum DX, for example. This is a nice idea, and there's a lot of different researchers working in this space as well. But the idea is that you have a diagnostic test, you hold your phone up to it, the phone recognises the test, it takes all of the information, it images it, it analyses it, and then it outputs the result, it offers you advice, all of these different interventions. This is a really great idea, but it's very difficult to do. So there's a lot of other approaches which try and go a halfway house. So things like the DECI reader, which is used as part of that earlier FINET study. This is basically, you create a controlled environment to put your test into and image it, and then you output the intensity of your line on your diagnostic. You can then connect this into an appropriate system. And then you've got the more simplistic versions of that where you take an existing smartphone, you put it on a cradle so it localizes it effectively, ensures it's all in focus, and then you take an image of your test. So there's a lot of different ways people are approaching this, but some might be more suitable for self-testing versus others that are perhaps more appropriate for a trained professional to use, particularly in terms of cost. So I think the area that I think is really interesting here is kind of this multivariate way that this can feed into being beneficial. So one is the mobile phone acting as a computer and imaging device to read out your diagnostic, removing human error from that process, but also in advising how you perform the test, ensuring that you're educated at the start of that, but then also connecting those results into healthcare systems and also enabling that feedback from the healthcare system, making sure that people can be linked and continue that linkage with patients downstream. And this is a really exciting space, I think, where we haven't really demonstrated the full potential of these kind of interventions in large-scale studies, but we're seeing lots of small studies that are showing a lot of great promise. In terms of self-testing more generally, this is something that's really starting to come into its own now. So, for example, the WHO is just has just released guidance last year into trying to help nations develop their self-testing platforms. There's a recent study in the Lancet, a meta-review of meta-reviews looking at this space as well. And so there's a lot of evidence to suggest that there's the potential of self-testing being quite revolutionary, but ensuring that it's simple and ensuring that we can tie that up to the next generations of diagnostics is somewhere I think mobile technologies can really help. So two of the funding bodies, one of which Mike's already mentioned, is iSense. So these have both funded the work that I've been doing and also a lot of the work that's been done within Molly Stevens' group. iSense is focusing more generally on infectious disease diagnostics and online care pathways, these whole systems of earlier disease diagnostics. And then Africa is more targeted and more recent, and this is looking at how to use mobile phones, mobile phone connected diagnostics and online care pathways to deliver optimal diagnostic approaches for HIV in decentralized settings. And this is focused on in South Africa with the African Health Research Institute. So what I'll do now is just talk about a couple of the technologies that we've been using or developing within Molly's group, but also are a key component of iSense and Africa as well. And these are trying to push the boundaries of, well, in the first example, it's trying to push the boundaries of sensitivity in lateral flow diagnostics. And the second example is just using the functionalities of the mobile phone more broadly. So this technology is something we published last year. And this is using a chemical amplification to enhance the sensitivity of a rapid test. So the idea is that you've got these coloured particles, and in the presence of a patient plasma sample that contains a viral protein of interest, in this case P24, that protein will stick those particles at a test line. They're coloured, so you'll see that at very high levels of the target protein, you'll see the buildup of this coloration. But in the very low sensitivity regime, where you've not got a lot of this target, it's going to be too faint for the eye to resolve, and so you then have a chemical amplification that can boost this signal higher, and you can measure the intensity of these lines using your mobile phone. So the mobile phone imaging process is relatively simple in the way that we use it. So we orient the system, we have a phone placed where we need it to be, on top of the test. We image these paper strips, so this is our test line here, and different concentrations of this antigen. You integrate over the test line, you get an intensity, you get a line profile from that, and you can measure the area under that profile, and then you can output your, semi-quantitatively at least, the level of P24 that's in that sample. And what you end up with is a dual sensitivity regime. So at very high levels of target, you can resolve that just based on the coloration of the test strip particles. And then after amplification, you can resolve that signal by the deposition of the coloured products that get deposited locally around. And the exciting thing about this is that it's getting us down into incredibly low levels of detection. So the Abbott architect I showed earlier on has a limit of detection somewhere in the tens of picogram per mil, 3 picogram per mil, 10 picogram per mil, that kind of range. We're able to match that at least with something that works within 20 minutes and is just formulated with paper, very small quantities of nanoparticles as well. We've done some very initial studies looking at seroconversion panel performance here, and we're seeing nice data, and the next stages are to look at actually testing this on a much larger series of patient samples to confirm it's working as we'd like. The next study is a recent study as well from Molly's group. So this was led by Polina Brangle, who's a PhD student in Molly's group and is now a postdoc at UCL and Richard McKendry's group. Rachel McHenry being the head of iSense. This work was trying to use the mobile phone as a quantification technology, but also as a way of geotagging results from patients that were survivors of the Ebola outbreak in West Africa in 2014. So they were in Uganda, and they were collecting patient samples, measuring them, and then tagging those geospatially, and also comparing them to other closely related viruses as well, so Bundibugyo and Sudan virus. And what you could essentially end up with is this map. So thinking again about epidemiological applications, having the ability to monitor people at a very local level, tag them in a live scenario, have all of that data transmitted into a healthcare system, and then monitoring that is very exciting and very simply done using a technology like this. Of course, you have to think about all of the big challenges of this though, which it's not just as simple as can we do this, it's whether it's secure, whether the data is used effectively. So there are a lot of challenges in this as to whether these kind of approaches can go on to the next stages. But I think it's really exciting to see where they're going so far. So that completes it for me. So just a few thank yous to all of the members of iSense and Africa, divided through Imperial College, UCL, RE, as well as some of the hospitals around London as well. And thank you to listening.
I just picked up, someone was monitoring the people from Uganda, people in West Africa being tagged. They're asking whether it was secure. So how would the people in West Africa know that they're being tagged by someone from East Africa or people from security?
No, so there was actually several components to that study. The study within Uganda was it was measuring the presence of antibodies to the Ebola infection previously, and then monitoring their location within Uganda. Polina has done several studies in other parts of Africa as well. I don't know whether there was any additional communication done with people in regards to your question, but
Basically, it was a bit like a pirate kind of sneaky way of monitoring, because people didn't know that we monitored.
so people were aware of their monitoring. So these are people that have donated samples to this study. Yeah, so in that sense, there's an ethical process that's gone through to obtain these samples from people. They're aware of this, the data is then anonymized, and then geospatial tagging is done to monitor where these people are.
Any more questions for Michael? If not, we'll pick it up on the panel. Sorry, Lee.
Yeah, just a quick question around, so you've spoken, you kind of touched on it briefly about the fact that self-testing is available, and we can definitely develop technology to support self-testing. How much do you think that the creators of that technology need to think about the service and the service provision around that self-testing? Because if you think about chronic conditions such as type 2 diabetes or HIV, no matter what the diagnosis is, that's important to that person, and therefore you touched lightly on kind of talking about services afterwards, or the idea that the mobile application might give some supporting information. But I think there's probably a gap with the services. The technology is fantastic and it's amazing that we're doing that, but what about the follow-up like you were talking about?
Yeah, I think there's a lot to be done in this space. There are interventions that people are trialling, which are things like the HIV Smart app. So I think trying to sort of move towards that, but I don't think anyone's done it particularly well yet. But I think that is what people want to achieve. So I think it's critical, as you say, that you not only need to diagnose people, but you need to support them at that time. Because particularly if you're self-testing, that's a horrendous time to be finding out a result like that if you're lacking that linkage into care. And it's one of the concerns of a lot of the HIV apps that are out there that are not revolving around diagnostics themselves, but they're poorly regulated, they're not necessarily helping you in the way that you need to be helped. So it's a really important point. It's not something that I'm personally looking into myself, but it is something that's really, really critical.
But there are other members of the iSense group who've had experience with pregnancy home kits and been some cross-fertilisation from those other examples of home testing. I think we need to move on and then bring you back at the panel, if I may, Michael.
So to follow up is Dr. Curek and Dr. Flott, who will be talking about the role of digital innovation for improving healthcare quality in extreme adversity.
Right, hello. Thank you all for coming and listening and staying around for our final talk today. My name's Kelsey Flott. I manage our Patient Safety Research Centre here, which is a joint grant between our trust and Imperial College. We kind of work on improving the evidence base around patient safety and then applying that in health systems, usually in the NHS, but also across the world. So this is this talk will kind of go into some of our more global efforts, which actually tries to bring our patient safety and quality work into a new territory, and actually slightly unfamiliar and uncomfortable territory of extreme adversity. So I'll explain what that term is and why we've been working in that space. And then my colleague Natalia Curek will go over some of the digital innovations that we've learned about, which can support quality improvement in extreme adversity. So to start, let's go over what extreme adversity actually is, because I think it's a somewhat dramatic term, which requires a bit of explanation. It was coined by Professor Sheila Leatherman, who is in North Carolina, and what it does is actually it captures something more than just low and middle income countries. It's something about fragile states, conflict areas, and sustained humanitarian crises. So really a term to capture absolute destitution and extreme vulnerability, which is hard to even define and articulate in one succinct way. But you can imagine the types of things that are included in extreme adversity. And we started looking into this because over the last kind of 20 years or so, since the original publication of Crossing the Quality Chasm and To Err as Human, there's been a large global quality conversation, which is really quite advanced, and there's a huge academic evidence base around quality and safety. And in 2018, there was a Lancet commission about quality in across the world, so in low and middle income countries and low resource settings, and thinking about, right, how can we actually formalise the quality agenda and what we need to do to improve quality in areas that actually aren't as wealthy or have the luxury of kind of excess infrastructure or money to spend on quality. Not to say that we always have that in developed systems either, but that's what this publication of Crossing the Global Quality Chasm did. And Professor Leatherman was part of that Lancet Commission and came to Imperial to work with IGHI and the Patient Safety Centre, and we realised that there really was still a gap. So we can talk about quality in other settings, but can we still talk about quality and improving it in the absolute most extreme conditions? And we like to think that we can, and we like to think about, okay, well, how can we actually improve quality in those settings? Because as you can imagine, it's very difficult to actually prioritise quality and improving it when the conditions are so extreme and so volatile. So the partnership between this project started with Professor Leatherman and IGHI, where we have a special interest in patient safety, but also in digital health. And we've worked with a series of healthcare safety experts and digital health experts. And it's important to note that this work is still evolving. So we had lots of interviews with experts in these areas, but it's in no way finished. So we'd like to continue to get everyone else's input into this and continue to learn. And the research question we've kind of been tackling is how can digital innovations improve quality in extreme adversity? So trying to kind of match up all of those different areas of expertise that we have. So that's where it comes from. And to provide a bit of context, quality is, we're not wedded to any one definition of quality in our centre or in this project, but it's important to note that quality over time has had quite a fluid definition and has been responsive to the kind of remit of the health service at that particular time. So quality has evolved in many ways to include these three components. In no way is this exhaustive or reflective of every single definition of quality, but what it is the kind of core components of any interpretation of quality, which is of course the clinical effectiveness of care, measured by actual patient outcomes. But as the quality debate has grown, we've also started to include safety in that. So not only the effectiveness of care, but the absence of harm and safety for staff and patients who receive care and deliver care. But it is further than that. So it's also the lived experience of patients who are receiving care, and also the lived experience of staff delivering it. So in the whole piece of work, these three components are seen as equal and not necessarily separable. And as you can imagine, it becomes harder and harder to prioritise some of these pieces when you're working in conditions of extreme adversity. But these three components don't become less important to patients and staff. So that's why we want to include all of them. Another bit of context is, I think here in the NHS it's fairly obvious how digital can improve quality. We've heard lots of examples of how it's fairly straightforward elsewhere as well. But just to kind of recap across the whole patient pathway, we have lots of digital innovations that have done really quite incredible things for quality. So, as we were talking about before, wearable monitors for vital signs, patient access to care really at the start of a patient pathway in prevention and community health. But then moving into actual care, so diagnostic decision support tools have advanced enormous way in terms of actually supporting doctors to detect patterns and to make accurate diagnoses. Then into actual care, this isn't just about how patients experience care, it's the ability for digital tools to help clinicians deliver care. So there have been lots of advances in virtual simulations of surgical procedures and extending expertise to people who aren't necessarily immediately present to receive training. So huge scope for training, but also platforms of delivering care. So e-prescribing systems are hugely different than just paper-based prescribing systems. And all of these things into things like incident reporting and electronic health records, which is, I think, what we often kind of picture when we think of digital health, are very clear in terms of how they can improve quality in the NHS, in a kind of high-income setting, but it's also very clear from the presentations today how they can be applied elsewhere, and how you can work within resource-limited settings to do some of these same things, and actually really to leapfrog some of the advancements that have been made in the NHS. But where we come to a concern is there a point where that stops? Can we always look at those roles for digital innovation and quality, or is there a point of such extreme adversity that these digital tools are irrelevant, or perhaps quality conversation might not be a priority? Because there are massive barriers to doing any of the things we just talked about in fragile states, in humanitarian crises, in conflict zones. The first of which is leadership. We talked briefly in one of the other sessions about how actually this all needs to be kind of combined. There needs to be a vision. These new technologies are only as good as the people leading them and the way they're implemented across the system. Without that leadership, it's very difficult to actually derive any benefit from the new technologies. Workforce training and local expertise. As we know from this health system, any new digital technology has the risk of not producing any benefits when a workforce is either untrained or completely burdened by the new technological device. My research background is in patient experience, and one of my favourite kind of stories about this is that when the Friends and Family Test was developed and we had to go around and ask patients how they felt about their care, lots of hospitals started doing that on iPads, and they thought, this is great, we're learning from patients. And then it turned out that patient experience scores went down because all the patients felt like all the nurses were just running around on iPads. And you think, well, this was meant to be something that supported patients, but actually it was an innovation where there was not sufficient training or coordination amongst the workforce to make it work. But there are more profound barriers than that in extreme adversity, which are obvious but important. So connectivity and infrastructure. These mobile devices, as we saw before, don't work when they can't be charged. So how do we move beyond those kind of barriers that rely on actual electricity or connection to the internet? And also violence and vulnerability. When we're talking about situations of war, and conflict, nothing is certain. So the ability to implement a long-term plan becomes even more difficult. So we're trying to work within all of these barriers to still see, well, what is the role? How can we leverage these great technologies to do something better for quality? So I'm going to hand over to Natalia to actually go over some of the answers that we've found.
Great. So following on from Kelsey, I'm just going to talk about some of the opportunities that these digital innovations have to support quality. And they are as much a product of the context as they are a result of all of the expanding technologies that we see. And the diversity of this context and extreme adversities impacts the needs, it impacts the preferences and the expectations of the people that are using the technologies. So we need to think as a starting point, really. Oh, sorry, I haven't actually moved my slides. So we need to think as a starting point as looking at these core ecosystems and what is still intact and what is actually being broken and disrupted, because this needs to be taken into consideration. So through our expert interviews, we identified 3 key areas for opportunities for digital innovations to improve quality of care. And the first one of these was data capture and surveillance. And this is both at an individual level and also at a system level. So one such example is the WHO surveillance system, which aggregates around 7,000 public health notifications for health threats a month. And using AI and machine learning, this can be diminished down to 300 threats, which then uses human resources to actually identify ones that need to be examined in more detail. So this cuts out a huge amount of workload, and it's these kind of innovations which are incredible. We can also look at workforce and preparedness and training. So this includes both upskilling of healthcare professionals, so healthcare workers and nurses, but also there's a lot of opportunity for training and supporting already current healthcare personnel. And another area of opportunity is, of course, clinical care support. So this is both in the delivery of care, both for communicable diseases and non-communicable diseases, and also in helping with the supply chain. So we're just going to look at this in a slightly different angle, and it's looking at how these digital innovations enhance different aspects of the system. So if we start with the possibilities for whole system enhancement, this includes the supply chain management and public engagement and communication. We've discussed earlier in some of the talks the amazing work of text messages to patients to remind them to come to appointments. But what we've seen in Rwanda is a zip line, which is using text messaging service for doctors and healthcare professionals to ask for blood and for medical supplies, and then drones come to the areas of extreme adversity to deliver these supplies. And in regards to patient engagement and communication, these digital innovations, these digital tools can be incredibly important in delivering and communicating messages about recent outbreaks and delivering accurate information. A lot of information that's passed on is hearsay, and these tools can be used to provide accurate information that these patients can use. Another area where we see enhancement is in monitoring and prevention, and we've discussed many of these earlier today. So for disease outbreak management and also for non-communicable disease management. And that's something that I think, we focus a lot on disease outbreak management in low and middle income countries. However, there needs to be a focus on non-communicable disease management and again, just the simplicity around that. So we move on to workforce enhancement. And we mentioned earlier education, training and distance learning. There's a huge opportunity here for upskilling, again, as I mentioned earlier, and also for just increasing the knowledge base and continue professional development in areas where there is very little access to further education. There's also an incredible possibility of introducing remote expertise. So one such example that came out of an interview was in the most recent Ebola crisis, where there were children as young as 6 months who were affected, and the personnel on the ground did not have the expertise to deal with these cases. And so through the use of telemedicine, they were able to link in with specialists from around the world who are hemorrhagic pediatric specialists, and they were able to give live communication and live advice as to how to treat these young children. Another area for these digital innovations is direct care provision. So that's the diagnostic decision support, as we heard Michael speak about earlier, for example, for HIV, and again for things like avoiding deterioration. So with the current novel vaccine that's being used for Ebola, there is a cloud-based system that is being used to monitor adverse reactions to the vaccine. And this is all being put together to alert those who are creating the vaccine, those who are delivering the vaccine, and just being able to have that log to improve quality and make a difference and move them forward. And of course we can't forget individual patient support. And that's something that we all think is probably core of this. I'm just going to move on to that for a little bit longer. So we speak a lot about patient experience. Kelsey mentioned how it's a core component of quality. And in high income settings, we involve patients a lot. We involve them in workshops and various other ways. However, frequently they're forgotten in these areas of extreme adversity, and many NGOs come in with their pilot studies, as we mentioned, and there's no sustainability, there's no actual involvement of the patients. So it's incredibly important that we involve them from the start. The best outcomes for the patients will come from leveraging and harnessing technologies that they already use and that they are comfortable in using, as opposed to introducing very new technologies which they may not be familiar with. And in adversity, we often see that patients seek multiple disjointed providers of healthcare, and this can cause havoc in their treatment schedule. And what the huge opportunity with digital innovations is that all of this care becomes very patient-centric and patient-focused, and it's the patient who owns their data and has the ability to lead on their healthcare journey. We've seen in higher income settings that when patients have involvement in their care, there are better health outcomes at a lower cost. So we really need to make sure that we don't forget about this in areas of extreme adversity. And what Mike Shaw mentioned earlier was, so all of this together with introducing digital innovations for improving financial services for people in extreme settings, for improving educational options, all of this together takes the whole well-being of a patient, and we move away from just looking at health of the patient, but also health and well-being, and all of these digital innovations can really help bring all of that together. And in order to harness these, we just need to look at 5 key areas. So policy and decision makers really need to focus on these areas. As I first mentioned, end user involvement. So that's thinking about the patient, so that's critical. We also need to think of stakeholder engagement. None of this can be done without leadership and without all of those who are delivering these innovations being engaged, trained, and motivated to actually help. The technical profile of these innovations needs to be simple, interoperable, and adaptable. As I mentioned earlier, we need to harness innovations that are already being used by patients, as opposed to trying to introduce too many advanced technologies. And also, of course, we need to take in the wider policy environment. So we mentioned sustainability, long-term funding. That needs to be taken in consideration, because a lot of what we see is these individual pilot projects coming in and then terminating, and there's no sustainability of that work. And of course, the extrinsic ecosystem, and that includes infrastructure, connectivity, and everything that we mentioned in slightly more detail before. And that's it. So I'll leave us now. I think we've got our panel discussion now.
Right, speakers could just join us, please. I think we've got 6 chairs and 5 names for some strange reason, but yeah. So before we start the panel, for any questions that you may have, just take any questions specifically to the last 2 speakers. Any areas of clarification? Just one then quickly. So, how are you taking this work forward that you've just been describing?
Yeah, absolutely. So we're still working with Professor Leatherman, and she's been on a kind of mission setting up a program for academic research in extreme adversity and actually kind of formalising what the term means. And so we're working with her to do that, and now we're actually trying to develop what is a first set of advancements and innovations that would be ready for use in these kind of areas. So taking the examples we have, seeing if they can actually be put to use. So I think that would be the next step.
And it's the same in your area as well?
Yeah, so it's the same project. So Sheila also recently had a small working group in the WHO where they considered the projects that we mentioned, and again continuing with the work that Kelsey mentioned.
And how does it address particular disease types or conditions? Does it come down to a particular set of suggestions that might be specific to a disease or a certain geography?
I think it could. I think right now we're still at the point of identifying what the best innovations are. And the problem is it's such a broad term and it's such a diverse kind of area that actually what works well in one context of extreme adversity in one particular fragile state might be absolutely perfect, but not quite right for another one. So I think we're still developing A, what are the criteria for something to make that innovation work and relevant in extreme adversity, and B, can it be applied elsewhere? So if it were to be disease specific, yes, but I think we haven't quite got there yet.
But I think the mechanism of gathering of case studies together, which might be compared and contrasted, might give better ideas anyway. So let's see how it progresses. So any questions to any of the speakers? People like, lady on the right, if you will.
Yeah, so I'm just going to play devil's advocate for a minute. I think the earlier issue was physician overuse. And by doing all these things and putting care in patients' hands, are we effectively generating generation of patient overuse?
That's a hard question. Who would like to take that? So I guess what you might be causing is some worried well type issues. If you describe these things in a very open way, you might also not be able to aggregate personalized data sources very easily if you personalize it too much. So does a new system start to create some unforeseen consequences, I think is behind your question.
Yes, yeah.
I don't think any of us necessarily know the answer to that. I think we would have to think about you know, how it could be applied in a more precise disease type way or country type way. I'm not sure we know, unless anybody wants to.
It just reminds me, talking of the worried well, I think there are millions of people around the world who are worried well, especially in the United States, where they have used mobile telecommunications for medical applications quite a lot. And the problem with the thousands and thousands of apps available out there is that you can monitor all sorts of conditions, monitor your heart rate, which is a straightforward one to understand. But interpreting what the problem is, if there is one at all, you're probably just monitoring your own good health. That's a big issue, and none of this is going to replace doctors who can look at a patient and diagnose them much better than technology often can.
There's some interesting experiments at Surrey University looking at voice communicators such as Alexa, and starting to see how could they be used in a nursing home or maybe in a supported setting. You know, and it's seen today that people are just calling up Alexa to say, play me my favourite Frank Sinatra, or am I well today? Please tell me if I'm not. You know, asking all sorts of interesting questions. And it's not a substitute for care in the community, but it's a tool in the mix. And I think we should be viewing these technologies as tools in the mix. There's no standard recipe. Any other questions? Yeah.
I think almost everyone on the panel mentioned frugality and kind of a lack of resource. But almost every example was to lower income countries or from lower income countries. And I think the appetite for potentially working in a frugal manner is much more acceptable or accepted in lower income countries. But some of the reverse kind of innovations that have happened or been attempted, where we look at frugal innovations that work exceptionally well and produce amazing results, and then are tried to there's an attempt to integrate them into the National Health Service or into the US. They're just not seen as acceptable for our health, quote unquote. And I think that how do we start to understand that populations themselves are stakeholders in their health, and almost empower them to make appropriate decisions and consider the fact that finances are important, and yes, we want the best healthcare, but the best healthcare isn't always the most expensive healthcare. Yeah.
Natalia, can you take that one? Because I think you referred to
Yes.
stakeholder engagement.
Yes, so interesting that you mentioned that. So within the Institute of Global Health Innovation, we've actually done a little bit of work on that. And as you say, there is cognitive bias in reverse innovation, so bringing innovations from the African continent or from India and introducing it into the NHS. And we do see that. And we did a study actually recently with Greg here in the audience, and that was looking at papers and say a technology introduced by a Harvard professor in comparison to a technology introduced by a professor somewhere in the African continent, and the cognitive bias there is huge. And I agree that's something that we really do need to work on. At Chelsea and Westminster, we're introducing a trial of the Arbitus drill, which was a drill that was used in Africa for orthopedic surgery and cost approximately 10 times less than the drill that we're using in the UK. And there are trials actually being undertaken at the moment. But as you mentioned, it does take a lot of stakeholder engagement and that conversation and that dialogue. I think we're beginning to start that, but I still think there's a long way to go.
I'm also not convinced that the frugal examples are well known to people who might wish to adopt them. I think we might have a conflict of systems, that's true, but I think the visibility of good frugal success developments is not strong enough.
Do you think the visibility that has been shared has been poor visibility as
Yes.
well?
Yes.
Because you hear a lot of terminology about cheap or easy or all of the very all of the words that kind of bring about the idea that it's not as good in comparison to, even if it is better, nobody wants the cheap option for their health. But I think any publicity around mosquito nets that can be used as tumour dressings or things like, or hernia repair, and the drill and lots of other things are better than, but are then termed cheap or coined cheap or easy. So I think the publicity around it is almost like a PR exercise.
Well, I think the exchange of case studies, I would guess we're all in favour of, but actually making the visibility of the frugal ones, I think, needs to be improved. You know, so.
There have in fact been hundreds of these so-called frugal and simplistic ways of using mobile technology around the world. In a lot of developing countries in Africa and South Asia and South America, in our book we've listed many pages and pages of these. They tend to be done in isolation, if you like, in that country, maybe in just part of that country, and they're not linked to any other project in another country. So there's a lot of disparity, really. But there's a lot of activity being done over the years.
Yeah, gentleman, third row.
And just picking up on that point, Talia talked about the studies that we've done, taking a look at cognitive bias. And you can say that we should be, that those frugal innovations should be making themselves known more explicitly. But one of the biases we found is that clinicians from one country look at countries which are very similar to their own countries.
They don't do that research.
Overwhelmingly, British doctors look at Canada, United States, and Australia, and vice versa. Very few look at innovations in Malawi or in African or Caribbean states.
So, gentleman in the front row there.
Just following on your point, I think you'll find that there are the companies that manufacture some of these products, such as GE, the device. They don't actually want to sell them into these countries anyway, because the premium is on the products in this country, as opposed to a cheaper product which is being sold in the other markets.
Lady down the front.
I wonder if Pam can recommend any products that are either wearable or easily portable that will, it doesn't necessarily need to be one machine to do all of them, but to measure blood pressure, oxygen saturation levels, EEG and ECG.
I'm not sure there is one product that does all of that accurately. However,
Reliable and not too expensive.
well, I would suggest that you have a look at the ones which are approved by either the US system or the European system, and the healthscouts.com website is worth a look. However, I would suggest to you that we're going to see a lot more in the next 6 to 9 months, which will be added to that website in time. There are certainly some companies like LMD in Switzerland that's got a very interesting approach towards some of those measurements you described. They don't have full approval yet. TLT Sensors has another one which is not fully approved yet. So it's a growth area, particularly on the wristbands. With regard to plasters, clearly Imperial knows a lot about the plasters and some of the sensors with plasters. I'm sure we'll see some developments in that area as well. But to me, looking at a website with a range that might be added to is the best answer, I think.
Thank you very much.
Any more questions? The lady on the left.
I think one of the speakers previously had asked a question about evaluation, and there was a comment about the lack of evaluation in digital health overall. And I was interested in evaluating patient engagement and being patient-centred, and how, as digital health moves forward at a rapid rate, should we be looking at doing proper evaluation?
Could you take that?
Yeah, absolutely. I think you're absolutely right, and completely echo the concern that actually as we bring more and more digital innovation into the kind of patient-facing space, it needs proper evaluation, and that evaluation needs to be kind of academic and rigorous, your RCTs of these things, but also patient-led evaluation. So there are ways of measuring patient experience with a particular app or device, which we have validated tools to do, and I think that's actually very affordable. They're kind of very quick, paper-based things that can be done, but also the kind of co-production of digital systems with patients, I think, is something that is becoming more and more apparent, and when that happens, it's much easier to kind of pre-post test some of these things to see if they do engage patients in the right way. And there's a couple ways of doing that, but I think it does boil down to a real co-production between industry, researchers, and patients.
I think there's also what information is good for the patient versus not good for the patient. So access to information can be overload or worrisome, but how can you get enough information so you can feel that you're informed about your condition, or you could transfer that information maybe to another country if you have a long-term condition. You know, some of the access and flexibility from the patient point of view, I think, is an important aspect of that. I'm not in favour of overload, but I'm much more in favour of moving towards international personal patient record summaries, which can be used if you are a traveller, or if you want to have access to a reliable chemistry chain in another country, for example. So I think the evaluation has got to be done from a patient point of view, but also from is it suitable for the individual as well for information level.
Do you have any form of regulation for digital health implementation and innovation, especially for the frugal projects?
There isn't here. I think next month the WHO is going to publish their digital health guidelines. So I think that could be another probably forum discussion. My suggestion is about how these will benefit the global healthcare system, but global regulatory thing there isn't here, because it's not easy.
GDPR and all that we're talking about.
Yeah, this is European. There are localities, not global, but there is European. GDPR, it's about
GDPR is just about data protection, really.
Yeah, that's what I'm saying. So with the healthcare, you can imagine digital health somewhere in Africa, people getting everyone's information, and there being no regulation, and the next minute someone says, "Oh, look, I understand you're suffering from, you're relative suffering from HIV."
I think the gap is the frugal bit. First of all, I think the frugal bit's not well picked up. The two main systems are the US FDA system and the European system. They're the two main systems today. But they do not go into the frugal area, nor do they necessarily link as they might need to in the future to some of the GDPR issues. So it's the gap.
So just a quick one, another quick one. So a company like IBM, they'll give anything for anyone to use their cloud technology or Watson or all that analytics for free. So there isn't even a cover from a bigger player to cover all the frugal developments. Could I just find that little
for free?
For free?
I don't think so.
Oh, they would.
For a certain limit.
No, I think we're confusing business models now with frugal devices or frugal solutions. You sometimes get somebody offering something to say, I'll trial this and use this and see what you come up with. That's a business model rather than being a regulated approach to frugal type offers.
I think I mentioned in the book about Google mobile health systems, and I think there is a big research. This will be a big research area, especially in adverse and fragile countries. But I think also there's an important thing is that we need to think after 15 years, are we still going to think about the what I call the smartphone-centric model, or we go beyond that? Because that's a problem. I think as long as we have, I mean, the question is how cheap smartphones will be. I mean, if you look at the Apple 10, it's 1,000, roughly nearly 1,000 pounds. But of course, there are smartphones, Android ones in India as cheap as $20, maybe
Less than that.
less than this. But my question is that the future about mobile versus digital health is that still is going to go the same pilot's way for 15 years. Companies spend billions and billions of dollars, and tell me one country that have a massive mobile health, application or something that tens or hundreds of thousands of people using it. They are all pilots, pockets. So unless we think beyond the smartphone model, I think we are going to go into the circle again.
Can I just argue with you a little bit? I think it is digital health, not mobile health, because I think digital health is a more rounded systems approach. But there are examples of wearables that are sold in the tens of millions today. You might call them Fitbits or an equivalent of that. You might say that's an example of an early adoption from a consumer point of view to do with wellness. But we might see other solutions which might come into diabetes or other more global conditions.
Question here. Question about scalability. We're hitting on all these little pieces, and in particular, how do we scale digital solutions in healthcare on a global level? Because spending 5 years researching something in one country and proving it there, as we just said, is not going to show that it's going to now go to other countries and solve solutions and problems. So I'm curious, in a crystal ball, what you think might be some ways to tackle that problem.
Who would like to go first on that?
I think the first thing is that, is there any other alternative solution to the model that we have now? Everything is based on, because if you're in, I think most of the audience thinking of digital health in the same way there are people thinking of mobile health. It's an app and a smartphone and sensor and sending data. So that's it. That's the maximum they think about. And one of the things that I am trying to advocate and work on is really the science of digital health or mobile health, the science behind it. And this, the new reborn artificial intelligence, and because it was there for 20, 30 years, but now because of the capabilities of computing, I think it came again in the last 3-4 years. And of course, the technologies like Internet of Things and how these are going to be connected. So there's a whole new thinking need to be done in order for that to get out of this bubble of, and make things really better than what they are.
To add on scalability, I think that there's a way to actually scale, probably slowly, that has to do with evaluation and coordination. So if we can actually get the evaluation of devices or apps or whatever right, to be able to identify the criteria that made it work in that environment and coordinate to see where those situations, those environments exist elsewhere, and see where we can map, because one solution is not going to work globally, but it could work in 10 other places, and we need to kind of coordinate that to see where we can do that smaller scaling.
Yeah, I can see that. I just want to add a supplement. I think the trend towards globalization will continue, but there's a bit of conflict around the personalization as well. People want to solve their health rather than everybody's health. So I think, how do you get the best of both becomes the question. I think the information is already being much more globalized today than rather than 10 years ago or 20 years ago, because the web has really helped that globalization of information. We might want the lower costs of some of the solutions that have emerged with globalization as well. but I'm not sure we're going to get a one-size-fits-all solution in the globalization era.
I think diabetes is a very good example about scale. We have now 600 million people with diabetes globally, and that trend is going to increase. And we don't know why that increase is still an unanswered question. And unless we really think of new methods and approaches to prevent diabetes from happening, we will end up in the same cycle.
Lady, the fourth row.
Thank you. So my company assists digital health companies and other companies to scale international, come into the UK or grow overseas. And apart from the panels of previous comments about regulation and requirements, what we've found is that it's actually about the human behaviour that's embedded within that system already. So if that system already encourages people to believe that they don't have to dip into their pockets to pay for general practitioners or hospital care, we find that in a Commonwealth country mostly, and alluding to that gentleman's previous point, those kind of systems are more likely to, or more readily going to accept something that's already developed in kind of Commonwealth style kind of country anyway. And looking further afield beyond human behaviour, it's who essentially picks up the tab after that. What's the consequence of that particular health? How do you think about that solution within that system?
Okay, any more questions? I don't know. So I think it's the last two questions, then we need to wrap up. So the lady on the right.
Hiya. I think a few of you touched on sustainability in innovation and low resource settings. I guess my question would be, what are some of the things that can be done to ensure that sustainability is embedded into things like pilot programs or other kinds of development programs, so that it just doesn't stop when the funding stops?
Well, that's the lesson about don't start the pilot unless you've got a better view longer term.
That's what happens.
Yeah, but I mean, sometimes the money's being chased to do the work. Sometimes people have got passion about getting on with something and they don't necessarily think about the sustainability.
I also think a key component of that is actually engaging with the local healthcare professionals. I think if you introduce a pilot which is completely run by international healthcare professionals, then that really does limit the sustainability of the programme. But if you try to upskill healthcare workers in the local environment and try and get buy-in from the local government and from the community, then you have a chance for actually making these programmes sustainable.
So last question, then we ought to stop because Robert needs to wrap up. So there's a lady in the middle,
So my question was around digital health and cultural change and resistance, because there are lots of great applications, there are lots of great ideas which are being researched. Once they are at the final stages of research and they almost approved and offered by the systems such as NHS, you then being hit with a massive resistance. So your healthcare professionals do not want to use the application, or an example can be, for example, one electronic patient record. At the minute we have GP records, we have hospital records, acute hospital records, all sorts of records for one patient, and none of them want to share information, for example. And once you provide, one digital patient record, no one wants to use it. So how do we go about addressing this resistance to change earlier in the whole process?
I think your slide with leadership and the other elements answers that. Do you want to pick that up?
Yes. So I think what you mentioned there also is that there's fatigue of using lots of systems. I think when you move to one system, hopefully you eliminate that fatigue of logging in and logging out of various systems. But as Mike alluded to, it's about governance and leadership, and it's a slow progress of cultural change. And Kelsey does a lot of work with culture change within this trust, and it really does kind of stem up from. It has to be from the clinicians going upwards. It can't be from the system. It can't be from the leaders within an organisation. So I think it is possible to change that culture.
Can I thank you all for the questions? I think we do need to stop, otherwise we'll be getting rather late tonight. Robert, up to you.
Yes, thank you very much, Mike. I would like, as you can see, this is a very important and a hot topic, and it will be for the foreseeable future, especially from the global arena. and we have covered a range of talks and a number of areas, very important areas, especially from Africa, from the conflict regions, fragile, adverse states, and I think I would like really if the institute and that we propose this becomes a series, not the first one, but a series that with specific topics. For example, the things that occurred to me about the adverse environments, the WHO digital interventions guidelines and how these can be implemented and can be improved, regulatory issues in digital health, examples from Africa, etc. So these can be a series of events, hopefully. So finally, I would like to thank all the speakers, Brian, especially Mike, Natalia, and Kelsey. Thank you very much. Final thing, and for you all coming and listening to this forum, one final thing is that the next global forum will take place on 21st of March in the Roger Bannister Lecture Theatre and will be looked at the topic of management of severe malnutrition. Well, thank you very much and enjoy the rest of your evening.